Good afternoon, everybody, and I would like to present my talk on cyanoacrylate tissue adhesives in corneal perforations. I would like to emphasize that all of us were young and we are starting, so we need to have tissue adhesive in our clinic, cornea clinic, always available, because you never know when you get a patient. And believe me, for corneal perforations less than 3 millimeter, although fibrin glue has picked up, it has several advantages, but this still remains a very valuable tool for most of us, and you can apply in several situations. These are various preparations available. We are fortunate now that now it is inexpensive. There was a time in early 80s that it was 10,000 vial and rupees per vial, and it used to be imported from Germany with the name of Histacryl. So there are several methods of application, but I would like to show the one which I am very much comfortable. The key is that you have to de-epithelize the area around the corneal perforation and around the corneal ulcer. This is basically a traumatic one where we have removed a wooden corneal foreign body and we have detected that there is a perforation. So in this case, we will be de-epithelizing, and de-epithelization can be done with the blade, it can be done with the needle, but in this case we will be doing with the help of the cyanoacrylate tissue adhesive only, that you apply the cyanoacrylate tissue adhesive first time and then remove it. While you are removing it, you will remove the epithelium also along with it, and then do the second application where the adhesion will be firmly to the surface. In traumatic corneal perforation or in post-surgery wounds, you need not keep it for a very long. You can just keep recheck after 2 or 3 weeks, and if the perforation is healed, you can always remove it. It can be applied to corneal perforation due to bacterial corneal ulcer, where the corneal perforation is there and your infection is responding, like in this case. And you can also apply to the fungal corneal ulcer. Again, you should be cautious that your infection is responding, because otherwise you will have problem. I have done few cases where I have combined it with the intracameral, intracorneal voriconazole, and it has worked well. Sometimes you don't want to apply bandage contact lens due to the risk of aggravation of the infection. So you can use a very small piece of drape which is sterilized, put a glue on it and apply it onto the corneal surface, so you can avoid the bandage contact lens. Sometimes you have very large corneal perforations in Murren's ulcer, like in this one. So there you need to put a scaffold in the corneal perforation, otherwise the tissue will go into the anterior chamber and will cause a lot of inflammation. So in these patients, I usually use a scleral patch, lamellar scleral patch, and put it in the corneal perforation, and if needed, apply few sutures. Like in this patient, we have applied few sutures, we have removed the glue, and you can see that there is a very good healing with minimal astigmatism, and patient has very good vision. So this modality works very well in selective cases. This is diagrammatic representation. This paper we published in Cornea. This is another way of doing corneal perforations, where you have a large, moderate to large perforation, and you have vertically corneal thickness is adequate, where you can make a lamellar pocket. So in these cases, I make a lamellar pocket and then use the same very thin scleral patch and put it in the perforation, and then apply very little glue. And then the glue is just to approximate the edges. This is just the diagrammatic presentation of the same one. And this is the surgical technique. We can remove the epithelium, like in most of all the cases we do. And after removal of the epithelium, we need to make an intrascleral pocket. This is a large perforation, so there in this one we can use even the crescent knife to make that perforation. So you can make the lamellar pocket using the crescent knife, and this is at least 0.75 millimeter more than the size of the perforation. Then you take the scleral patch and make it thin as per your requirement, and you can easily insert it into the corneal perforation if you have adequate thickness. So this is one technique which is handy if you have good thickness. These are some of the cases where we have done this, and this again be published in Cornea. This was very interesting patient where we have a corneal melt with the limbus melt, scleral melt following pterygium surgery, and it was referred to us for management. And there was no way we could manage this patient. So what I decided that I will use the scleral patch behind the cornea and put little bit of tissue adhesive. Of course, I did peripheral iodectomy in this patient and then applied amniotic membrane and used the medical treatment in this patient. This is just a diagrammatic presentation of the same. And this is the outcome in this patient, that the corneal perforation healed. Of course, there was a lot of scarring. He developed cataract. We removed the cataract, but he was not willing for any further visual rehabilitation. So this paper again we published in Journal of Ophthalmic Vision and Research. I would like to say that of course, fibrin glue has several advantages over cyanoacrylate in terms of healing and less corneal vascularization. But in case of emergencies where you need immediate closure, probably cyanoacrylate tissue adhesive has advantage. These are some of our publications. And recently we have published one review in clinical ophthalmology with authors like Dr. Professor Jagatram, Professor Nirankari, Professor Namrata Sharma, and Dr. Sayan Basu. And if you have any need to read more, you can go to this one. I would like to say that you see this picture, and all these dark shadows you are seeing, they are camels. But believe me, they are not camels. The camels are the gray shadows only. This is the aerial picture. So the corneal perforations can be as deceptive as this picture. So you have to really look for the perforation, do the Seidel test, and then depending upon the cause, size of perforation, you have to select the modalities. My colleagues, they have elaborated all the modalities of treatment of corneal perforations, and I thank them, and I thank you all also for patient hearing. Thank you so much.